If someone just told you that amputation is your only option, there's something they didn't tell you first, and what I'm about to show you could change everything. Maybe a doctor in the ER told you there's no blood flow and nothing could be done. Maybe you've been seen by multiple physicians and they all said the same thing. Maybe you're sitting down right now with a recommendation on a table and a consent form somewhere nearby, and something in you isn't ready to sign it. I've spent almost 2 decades doing nothing but the most complex foot and ankle cases, the ones other doctors have already given up on. And there's a pattern that shows up again and again. Most people are never told about it until it's too late. Here's what I've seen. Over half of the amputations being recommended in this country are being recommended before even the most basic test for blood flow has been performed. Half. And what happens after an unnecessary amputation? That's something most patients are never warned about before they agree. In this video, I'm going to walk you through what actually happens when you get a recommendation like that, what the standard of care is missing, what questions you need to be asking, and what your real options look like before anyone picks up a scalpel. Most doctors run out of options long before medicine does. Most patients believe that when a doctor says amputation, there's nothing left to try. The doctor has exhausted every option, done every test, and the conclusion is final. Patients trust that by the time those words come out of the physician's mouth, the homework has been done. This belief exists because most of the time, doctors delivering that recommendation is completely sincere. An emergency room physician, a general orthopedic surgeon, even many podiatrists, they're not trained in the full toolkit of limb salvage. They know what they know, and they reach the edge of what they know. They offer the most conservative path available to them. This path is often amputation. But here's the problem. Reaching the edge of one doctor's knowledge isn't the same thing as reaching the edge of what medicine can do. These are two completely different things. And for the patient sitting in that room, they look identical. You weren't told that there was nothing left to try. You were told that there's nothing left that particular doctor knew how to try. Those aren't the same sentences. There are advanced methods for restoring blood flow to a limb. There are antibiotic protocols and surgical approaches that can resolve bone infection without removing it. There are muscle flaps, skin flaps, and artificial skin substitutes that can address virtually any level of tissue loss. These tools exist. They're being used. They're not evenly distributed across every medical practice. Here's the standard to hold a recommendation to. No part of the foot, no toe, no section of the ankle or leg should move toward amputation without a confirming attempt to save it first. That's the bar, not whether one doctor has run out of ideas, whether every available tool has been applied. Bill was 58 years old when he came in. He had a chronic infection in his heel bone, osteomyelitis. He's already been seen by 7 other physicians. His last 3 opinions all said the same thing: amputation, no other option. Using 2 local surgical techniques to address the infection, he was walking immediately after the procedure. 7 years later, Bill still has both legs. He wears diabetic shoes and inserts. He walks. That outcome was available to him the entire time. It just required someone with the right toolkit. When you shift the question from is the doctor recommending amputation to has every available tool been applied by a specialist in limb salvage, the decision looks completely different. You're no longer at the end of the road. You're at the end of one doctor's road. That's a fork, not a cliff. In a moment, I'm going to tell you what happens to the body after an amputation that most patients aren't warned about before they consent, and why getting a second opinion isn't just about keeping a limb. Half of all amputations happen without a test that could have saved the limb. Patients assume that a recommendation to amputation comes after a thorough diagnostic workup. They assume that if blood flow to the limb has been assessed, it's been assessed completely. The word testing implies rigorous. It implies that someone has checked everything worth checking. Most patients aren't trained to interrogate a medical recommendation. They're not asking which specific test was performed, what those tests can and cannot detect, and whether more sensitive vascular assessment was ever ordered. They trust the system has a process, and that process was followed. That process wasn't always followed. More than half of the amputation recommended in this country are recommended without a simple vascular study that would have revealed whether blood flow can actually be restored. This patient is told there's no blood flow and there's no way to heal, and that's the basis for the recommendation. But the test that would have shown whether blood flow could be improved with intervention was never ordered. Patients are losing limbs based on incomplete workups, not failed workups, incomplete ones. The test that might have changed everything was never performed. Vascular assessment isn't a single test. There are basic screening tools and there's advanced diagnostic studies. There are interventional techniques that can restore circulation to a foot that's been written off. When a specialist in limb salvage looks at these cases, what becomes visible is that the pathway to saving the limb was there. It just required someone who knew how to look for it and had the training to pursue it. Before any decision is made, the complete vascular picture needs to be on the table, not a screening result, a full assessment. And if the blood flow is compromised, the question that needs to be asked is whether it can be restored, not whether it's currently insufficient. Those are different questions with completely different answers. Allison was 43, a chronic diabetic with Charcot foot, a condition where the bones of the foot and ankle collapse. After a failed reconstructive attempt elsewhere, she was told to give up or accept amputation. She believed her walking life was over. A full MRI and CT workup showed what was actually happening structurally. A staged surgical approach addressing the soft tissue first and then replacing the damaged bone with metallic spaced implants. Alex returned to regular shoes. She walks normal. The information that made that outcome possible was available in the imaging. It just required someone willing to do the complete workup before closing the door. The question to ask before consenting to anything is specific. Which vascular studies were performed? What were the results? Has a specialist in limb salvage reviews those results? That one question changes the trajectory of the conversation. And now I want to tell you about the piece of this that almost no patient hears before they sign a consent. The cardiovascular consequences of an amputation that wasn't necessary. Before I get into that, if you're watching this because someone in your family has been told that amputation is the only option, or because you're in that position yourself, hit subscribe. Every week I put out a video on real options for complex foot and ankle conditions, what patients aren't being told, and how to advocate for the outcome you deserve. Hit subscribe so you'll get the next one. What they didn't tell you, 80% of diabetic amputations are gone in 5 years. This is the part of the conversation that almost never happens in the room where the recommendation is made. The focus is on the limb. The focus is on the wound, the infection, the x-ray. What doesn't get discussed is what the research shows about what happens next. When a diabetic patient undergoes an amputation, the mortality rate isn't subtle. The 5-year mortality rate after amputation in diabetic patients approaches 80%. 80. That means the majority of diabetic patients who have an amputation are no longer alive in 5 years. The cardiovascular system responds to a major amputation under those metabolic conditions in a way that accelerates decline. The heart is carrying a different load. The systemic inflammatory burden changes. The body wasn't designed to lose a limb and continue as though nothing changed. Ask yourself these questions before agreeing to any recommendation. Has anyone explained the 5-year mortality data to me in a context of my diabetes? Has anyone told me what happens to my cardiovascular health after this procedure? Was I referred to a specialist in limb salvage before this recommendation was finalized? Were complete vascular studies performed? And were the results reviewed by someone trained in restoration? Has every non-amputation option been explicitly named and attempted? This isn't about second-guessing every physician you've seen. It's about recognizing that an amputation recommendation, especially in diabetic patients, carries consequences that extend far beyond the limb. The decision being made in that room isn't just about a foot or a toe. It's about how long that person lives and what their quality of life looks like. So what do you actually do next when you're in this situation? That's next. The one move that changes everything before you sign anything. The single most important move available to any patient facing an amputation recommendation is to pause and get a second opinion from someone whose entire practice is built around not amputating, but second opinions from other generalists. A second opinion from a podiatric surgeon who specializes in limb salvage. This is a distinct specialty, not the same as a general podiatrist or an orthopedic surgeon. The training is different, the toolkit is different, and the outcomes are different. The cases that come through a limb salvage practice aren't easy cases. They're the cases that have already been through other hands. They arrive carrying 3 or 4 or 7 prior opinions. They carry consent forms that have been sitting on a kitchen table for 2 weeks. A meaningful number of them leave with their limbs intact. Not all. Some amputations are genuinely necessary, but the ones that weren't necessary deserve the chance to find that out before the procedure happens. Stop treating your first recommendation as the final answer. Stop assuming that because a physician is confident, the recommendation is complete. Stop signing anything under time pressure created by somebody else's schedule. A wound that has been present for weeks or months doesn't become emergency because a physician is busy on Tuesday. Start asking specific questions. Which vascular studies were performed? Has a limb salvage specialist reviewed the case? What would the approach look like if we attempt to save the limb first? What's the timeline and the risk of spending 2 weeks pursuing a second opinion before deciding? These are reasonable questions. A physician that won't answer them isn't a physician you need making this decision. And for anyone watching this who doesn't have easy access to a specialist or who's in a different state or country and wondering what recourse exists, the last point is for you. You can get a limb salvage expert to review your case from anywhere. The barriers most patients hit when they hear second opinion isn't geographic and access. The specialist in a different city. The appointment's 3 weeks out. The surgeon is pressuring a decision now. These are real constraints that are worth naming. They're also not the full picture of what's available. A limb salvage specialist can review imaging, records, and lab work remotely. A phone call with someone who's reviewing the documentation can fundamentally change the information a patient is working with before consent. This isn't a substitute for in-person evaluation when that's possible. It's an option that exists, and most patients are never told about it. Think about what it would mean to a carpenter if someone told them the only tool in existence was a hammer. Every job would look like a nail. Every cut, every joint, every repair, all hammered. That's the reality of getting a recommendation from a physician whose training gave them one primary solution to a complex problem. The carpenter isn't wrong that hammers exist. The carpenter just isn't aware of the full workshop. The second opinion from someone who has built a full workshop can change what gets built. An unnecessary amputation in a diabetic patient isn't a conservative choice. It's a cardiovascular event waiting to happen. Choosing to pause and verify isn't delay for its own sake. It's due diligence for a decision that can be undone. The limb can be removed next week if it turns out to be the right call, but it can't be reattached. If you or someone you love is sitting with an amputation recommendation right now, here's what to do. Write down the name of every specialist, of every physician who's been involved in this recommendation. Note whether any of them specialize in limb salvage surgery. Put together every piece of imaging, every lab report, every wound photo you have access to. Organize them by date. Write down the specific tests that were used to assess blood flow, and look up whether those tests include advanced vascular assessment or is it just a basic screening. Identify a podiatric surgeon who specializes in limb salvage, specifically someone who performs reconstructive foot and ankle surgery and has training in wound care. This is the person whose opinion you need before any decision is final. Contact that specialist. If geography is a barrier, ask explicitly whether remote record review is available. The answer may surprise you. You don't need to make this decision alone. You don't need to make it based on a single opinion. The tools to save limbs that are currently being recommended for amputation already exist. They're not experimental. They're not rare. They're simply not evenly distributed to every patient in every setting. The most important thing you can do when someone hands you a recommendation that can't be undone is to make sure the full range of what's possible has been applied by someone trained to apply it before you agree. If this lands for you, watch the next video, because the follow-up question almost every patient has in this situation is about peripheral neuropathy. They've been told there's nothing that can be done about the nerve damage, and that belief is driving decisions that don't need to be made. That's exactly what the next video is about. The link is right here. Go watch it.